An academic public policy analyst recently said, institutional trust is paramount in healthcare. Lack of faith in the government, public health agencies, the healthcare system, and even science itself can seriously undermine public health efforts. If people don't trust you, they're not going to do what you say. The pandemic occurred during a period of declining public trust in all social institutions, and its consequences for public health were particularly dire. Here to reflect on the past, the pandemic present, and the future of public health is the retired Dean of the Colorado School of Public Health, Dr. Jon Samet, an award-winning epidemiologist, scientist, and leader in public health. Dr. Samet, we welcome you and look forward to your remarks.
Well, thank you, Carl, for the very nice introduction. I wish that I were retired. I'm trying to figure out, because I stopped being dean 18 days ago, and there seems to be an awful lot of stuff left for me to do. So we'll see. So let me ask, I know some of you have health backgrounds. How many are health care providers of one sort or another? A bunch? Public health? I'll keep my hand up. Okay, so I'm unique here. All right. So I'm going to give you a lightning tour of public health and go through some things that have happened. I mean, I think, 5 years ago, I might have spent a lot of time saying, gee, public health is really important and we should pay attention and we do lots of stuff that people should value. Hopefully now I don't have to do that. So let's start with what is being healthy. And some of you may be familiar with the World Health Organization definition of health. This is from the Charter from 1948. A state of complete physical, mental, and social well-being, and not merely the absence of disease, illness or disease. So if you think about that, I like this definition. I think, how many days do I get up and I may not be healthy? My sense of well-being is off. And if you start piling up all the diseases, say, in the United States that people have, hypertension, heart disease, lung disease, mental health issues, and go on, this is an aspiration for all of us, but it's what we are after. Now, you can ignore this, except that what it shows that what makes us healthy goes from our molecules and genes at the smallest level to, at the top level, global factors, some of which are just totally out of our control. And not only that, all these factors play out over our lifetime. Okay, so what happens in your childhood may be important for you when you're 70. It may be important for your children because your genome perhaps gets, or your epigenome perhaps gets imprinted. So just to show that this is a reality, here is tobacco, where at the gene level we're learning that there are certain genes that may increase risk for nicotine addiction or perhaps getting COPD. And at the top level, there are global factors. So, for example, the multinational tobacco companies. The biggest tobacco company in the world is what? This is a trick question. Guesses? Speak up. Somebody make a... Philip Morris International. Good guess. Number two. Number one, the Chinese government. Okay, through the state tobacco monopoly. China National Tobacco, but there's about 5 or 6 big companies now that control the market. On the control side, the World Health Organization has the Framework Convention on Tobacco Control, the world's first global health treaty. So all this stuff up here is important, then down here is important. Family's important. Parents who smoke are more likely to have children who smoke. Whether there's advertising in the neighborhood, smoke-free policies, all those things figure in. So when we think about health and public health, we've got a lot of points for intervention. And for tobacco, we've intervened pretty well from top to bottom, or bottom to top. We talk a lot about social determinants of health, what's around us, where we live, who we are, what our work is, where we buy our food. All those things drive health. I lived right in the middle of Baltimore for 14 years while I was at Johns Hopkins. For many of those years, if I wanted to buy fresh vegetables, I had to go to the suburbs. It was a food desert, centrally. So there's a lot of things that drive health, and the impact can be extraordinary. So this is a paper that I'm never going to forget. It was published in the New England Journal of Medicine in 1990, and it shows survival over by age. So those curves show how as people start at 100% alive, there's survival curves, they go down. And you want your curve to go down more slowly, which means you live longer. And you can see now we have, on the left we have males, on the other side we have females, we have US white rates overall, we have Bangladesh, and we have males, African American males in Harlem. And you can see how steeply that curve drops, all driven by these social determinants of health. This paper includes an analysis, finer grade analysis of New York City, and there's about a 20-year discrepancy in life expectancy across the city, moving from those places where people did best to Harlem. So social determinants, critical, we talk a lot about them. What's public health? This is a book by an author in New Mexico. He's talking about his wife, who's come to see this pulmonary physician who at the time had prematurely gray hair. That was me. And this was a long time ago. But essentially, they come for a second opinion, and I'm left, sadly, with the job of saying that she has an inoperable lung cancer and is going to die. A conversation I had many times in my clinical days. And you can see her comment, "You must have the hardest damn job in the world." And the contrast, and this is from Hopkins, which branded itself with this protecting health, saving lives, millions at a time, which is what public health is about. So unlike my one-on-one encounter with this patient, if I'm doing public health, I'm perhaps having encounters with millions. They don't know I'm encountering them. They don't know that maybe I added something to their life expectancy or quality of life. And so protecting health, saving lives, millions at a time. And so there are definitions, of course, and here they come from CDC and others, and basically they all say public health is about making populations, groups of people, healthier. And that's what we do. So instead of interacting with people one by one, which we do sometimes, we're trying to do things that will influence and make everybody better. I had this experience years ago of talking to a group of high school students, and I said, "Do you know who Jon Snow was?" And they looked at me like I must have been the stupidest person there was, because everybody knows who Jon Snow was because he was the favorite character in Game of Thrones, which only I did not know. So they enjoyed my ignorance. And the Jon Snow I'm thinking about is the one who identified waterborne transmission of cholera before we even knew there was a cholera vibrio organism. An interesting guy. He was also one of the first to use general anesthesia. Gave chloroform to Queen Victoria for childbirth. So interesting guy. This is a mini description of his work for the Broad Street Pump in London, in Soho. And the key is he identified waterborne transmission. He actually didn't go remove the handle from the Broad Street Pump, which was where the source of the cholera, the contaminated water. He recommended that to the village council. So the model that comes along that we still use is he identified the cholera outbreak. He swept across London in the mid-19th century. He inferred that water transmitted cholera, which was a departure from the miasma theory of the time, that it was air. He recommended removal of the pump handle, and then he continued tracking to see what had happened. And this is sort of a paradigm that we still use. We watch over the health of people and identify problems. We gather data about those problems. We use that to seek solution, develop evidence, and then we look for ways to move from what we know into action. Sometimes we do that really quickly. SARS-CoV-2, COVID-19. Sometimes we do it too slowly. Smoking and lung cancer. How many years from Camel, first mass-marketed cigarette in 1913, first studies on lung cancer, late 40s, early 50s. Took too long. And then we keep tracking and do surveillance and keep watching. Now, the paradigm here is using what we know, and we're often left with uncertainty. And we have to be very clear about what we know and what we don't know when we're ignorant. And ignorance generates uncertainty. We're in this new world that I don't need to tell you about, where there's doubt, there's manufactured doubt, something that I have to credit the tobacco industry back in the 50s and setting the paradigm in place for discrediting science. And now we have this post-truth world where essentially anyone can say something, and by saying it, claim that it's true. You may have noticed. Few books to read, books with titles like Ignorance and Failure, they're wonderful. So what do we do in public health? I showed you that Jon Samet paradigm. Here's the basics, the 10 essential public health services. Per the textbook, we assess problems, we develop policies, we put them into place, we make sure they're working, we keep regrouping. And I think you saw this, again, play out in real time with the COVID pandemic. So this is what we do. Now, oops. Yeah, so what does public health do? Well, we do those functions. We don't have really a national public health system. So the idea that we have a public health system nationally is just not the case. Colorado, we have local control. We have 53, 54 health departments that can do their own thing. So we have a patchwork system with failings revealed during COVID. We're not doing as well as we should in our health. Here's a picture of death rates over time for major things. You can see the 1918 flu epidemic up there in that green line. You can see infectious disease deaths dropping long before we had antibiotics because of public health. You can see the rise and fall of lung cancer. And when I get the data to extend this out, we're going to see infectious diseases bump up. Again, of course. This was in yesterday's or today's New York Times. It's a plot of life expectancy by state, the pink. Notice life expectancy, of course, higher goes up. You can see all the countries above 82 in life expectancy. Japan, well-known, Australia, Italy. And then look at our states. And look where they are, and look at Mississippi and others going down into the low 70s. And this is in the face, excuse me, and this is in the face of our extraordinary expenditure on healthcare that we're also well aware of. So per capita spending up there in the green, we're way ahead of everybody else. And we're clearly not getting the public health, the life expectancy that we would hope to have. If we look at how disease rates are changing in the United States, we do know that Alzheimer's and dementia will become more important. Lung cancer is falling. Heart disease remains prominent. Depression, mental health, probably more important. And here's Colorado. Again, 1990, to 2019. And notice that self-harm, falls are important in Colorado. And we have the mental health crisis. This is the extraordinary figures of overdose deaths. And you can see the exponential rise, a problem that remains unsolved and worsening. So again, public health, using its approaches, is going after this in many ways. I'm going to march us through the pandemic. Quickly, I want to get to lessons learned. This is hospitalizations, up, down, up, down, up, down. You'll remember your old friends, Delta, Omicron, XB this, we're EG, whatever now, and we tracked those carefully and made policy decisions in real time as the pandemic played out. Now, in contrast to our 1,800 and something in the hospital statewide, we have about 70 or 80, maybe edging up, which is happening nationwide. We know that the pandemic did not play out equally across our state for many reasons. And again, you can see some of our more rural communities lighting up as hotter. And the same was true across the United States. Many things played into why there was so much variation in mortality. Again, lots of lessons learned. And compared to other developed countries, countries in the OECD, we did not fare as well as some others, again, for a host of reasons. We're trying to deal with long COVID and understand what it is, how much of it there is, and what to do about it. The National Institutes of Health has a number of long-term studies in progress now. So I think stay tuned on this. So let's turn to after the pandemic. What do we need to do? Well, our public health workforce has been stressed. Good people have left in Colorado, good people have left elsewhere, and they've had problems ranging from the general stress of the pandemic to personal attacks. Our data systems failed us locally and nationally, and they need to be rebuilt. Some funds are flowing, but I've yet to see a plan for what we really need. We need to enhance resiliency. We need new technologies. We need to communicate. We need to communicate better about what works and counter communications about what doesn't work. I chaired a committee at the National Academies of Science for about a year. We released our report in November 2022. We were charged with developing frameworks for how to deliver respiratory protection to the nation. Kind of a big job, one that we couldn't do at the start of the pandemic, you'll remember. And we couldn't even deliver toilet paper. This report says things like Congress should do this, White House should do that. What has happened, of course, is nobody has done anything because these kind of big problems that require system development and implementation just don't seem to get done. So I'm worried that if we needed to distribute 2 million N95s on the East Coast because of wildfire smoke, we can't do it. We don't have any respiratory protective devices for children, okay, or, Gary, people with beards. These are problems. So we need to address these things I just listed. The misinformation, disinformation problem is a big problem now. And with the rapid spread of information by people who are willing to say things that are not supported by evidence, and the rapid spread, we have a problem. I will say that I credit the tobacco industry back into the early 50s when we had what are termed sometimes the secondhand smoke wars back in the 70s, 80s, 90s over the science on secondhand smoke. The tobacco industry had a huge range of strategies. My colleague and I talked about them here in this article, Turning Science into Junk, Fraud and More. And they used a variety of strategies to do this. They had a whole playbook. And of course, under the Department of Justice litigation, Judge Kessler found them guilty under the RICO statute, a statute that's recently in the news again in Georgia, as you know, or the Georgia RICO statute. So they were found guilty, but the tactic has spread. And again, I will just say that here's just a whole set of the kinds of things that we contended with. One of my favorites, 5G. This led to the destruction of cell towers in the UK. I had chaired a group for the WHO on this probably about 13, 14 years ago, and now every time something happens with 5G, I get a call. This one was one of the most amusing. And it just goes on and on and on. And of course, things have been politicized. Expertise is dismissed, and politics are here. At the start of the Trump administration, I joined with colleagues who had been leaders at the Environmental Protection Agency, and we wrote this: the Trump administration and the environment heed the science. With this quote, scientific evidence does not change when the administration changes. Of course, EPA was turned inside out during that administration. And again, we have this sort of two culture problem of those who are heeding the science and those who aren't. So my friends wrote to me and said, what a great article. It's exactly what I would have said. And I think those who we wanted to read the article, of course, probably did not. Just a last thought. Climate change has been labeled one of the biggest public health threats of the 21st century. There's a lot of work starting, and I will say our school is working this around climate change and health, whether it's heat, of course, which has been prominent this summer, changes in air quality, changes in infectious diseases because of changes in vectors, social disruption, forced migrations because of sea level rise, and so on. So work is beginning, and again, this question of how will the evidence make a difference? Evidence on climate change and health make a difference? I'm not sure, because, again, evidence is not clearly the biggest driver of what is happening. So I'm going to stop roughly here before I get the hook from Gary, and some books, a few recommendations. This is on the infectious disease side. If you haven't read John Barry's book about the 1918 flu, read it. It's prescient in terms of the lessons learned for now. And I will just offer in closing the reminder that we have a School of Public Health, the Colorado School of Public Health, based at Anschutz with partner campuses at CSU and UNC. So thank you for the invitation to join today, and I look forward to having a conversation with you.
Hi, thank you very much for your talk. I'm just wondering, given that we have CDC and NIH, is there any movement at all in Washington to create some kind of national coordination of public health?
So, great question. Look, I can point you to article after article, report after report, of course, that talks about how we should be organizing, reorganizing. I think what you have to understand, and you probably do, is that CDC is advisory, but really has no sort of public health authority. It issues guidelines and so on. It captures certain scientific expertise, of course. Testing failed at the start of the COVID pandemic, in fact. And, we have offices, the ASPR, we have the Assistant Secretary for Preparedness within HHS. So there are a variety of offices potentially concerned with public health response. We grappled with this in that report I showed on respiratory protection because exactly that comes up. There's no single person with a title that you could say, hey, we're having a public health crisis, do something. And that proved to be a real problem. And just around respiratory protection, where I know the area well, you have CDC, you have subparts of CDC involved, including the National Institute on Occupational Safety and Health, which certifies the respiratory protective devices. FDA is involved depending on the jurisdiction. Other pieces are, so even coordinating is a challenge because there's nobody in charge. We did a lot of talking with folks when I was on that committee. Some of the people who are heading up these offices are longtime friends and colleagues, and they said, look, we're happily coordinating on a voluntary basis, but I think we need the place you walk in and you know that somebody here is going to bring everything together. So I think we'll have to see where this goes. But the structural issues may just exceed what can happen within a singular administration or in a very divided government like now.
Stand up. She won't give me the mic until I stand up. Thank you so much for your talk. I really liked your yin-yang of evidence and what needs to be done. I submit that belief and trust affect enormously what people accept as evidence and what they accept as ignorance and so forth. And not much about beliefs, but I'm curious, among your list of things, you don't list build trust. I think that building trust is a key element. I wonder if you have any ideas about what public health people can do around the country now to build trust in the system.
Sure, and we do talk about that a lot. And a lot of trust, of course, has been destroyed, and a lot of it, unfortunately and unnecessarily, of course. And, this politicization of public health where you can have sort of pro and con when everybody should be pro is a real problem. How do we, quote, restore trust? I think that's going to be, I will say there are people talking about this. There's committees looking at it. There's groups looking at how to combat disinformation. Maybe time will help when we get away from COVID. It's not that public health was not political before COVID. Of course it was. But not in such an in-your-face way. And nor was the disinformation, the dismissal of expertise, such a problem, which I think goes beyond public health now, in fact. So I fully agree with your pointedness and say it's a problem. I think it's going to have to happen sort of at multiple levels, local on up. I mean, to me, local public health used to be a good place to turn if you had a concern. You got sick after eating in a restaurant or whatever it was, and hopefully that will come back. But I mean, here, in Colorado, for example, you probably all know about the dissolution of the Tri-County Health Department, which was a terrific organization, essentially gone because Douglas County commissioners didn't like mask mandates, among other things. So, we will have to restore trust and I think belief in science or acceptance of the scientific evidence, which is part of this. And I will again just say that, things we're talking about here are going on nationally. They're going on with many other environmental agents, for example.
We have a question online. Nancy, would you like to unmute yourself, please?
Yes, thank you. I'm calling from Las Vegas, Nevada, and it's great to see everybody at the meeting here. My question to you, Mr. Samet, is do you think that there is a correlation with over 1,000 athletes suffering from cardiac arrest with COVID-19 vaccination? And is it public health addressing this with the young athletes and their families?
So, I take the point that there have been cardiac problems identified, particularly in younger males, post-vaccination. Myocarditis, I guess, has been the principal issue. It's and I think the question of what might be the longer-term significance and is there any will come from doing the right studies. What I can't answer for you is, has that particular population been singled out for follow-up? I mean, the NIH is putting together these several very large cohorts to follow up, and presumably will include such individuals, and we'll see if this is hopefully a transient and unexpected consequence of some vaccines.
This will be our last question. Thank you.
Thank you so much for coming here and speaking today. I had a question, and I couldn't help but be curious about the amount of expenditure in the United States and the results of that compared to other countries. But I was wondering, is there something we can point to for that? I know that there's a lot of food issues here, and I took a lot of classes on, say, like endocrine disruptors in our food and preservatives. I was wondering if there's something different that we're doing as opposed to other countries, and if you have anything to share about that.
Sure. I mean, there are certainly many things that make us not healthy. Some are perhaps more prominent here than in other countries, although I mean, some of our longer term things like the persistent chemicals that are endocrine disruptors are unfortunately everywhere. I think if you look at what the health economists write, they will tell you that we have a very expensive, inefficient system, or lack of system, I think is a fair way to put it. And I think the health economists will point to pharma and the high costs of drugs here. They will point to the high costs of healthcare delivery and a very expensive system. I mean, you know, of course, that we lack a national healthcare delivery system, and we are left with this very expensive patchwork. I mean, I think the two things that, if you remember, one is that plot of life expectancy state by state by state and country by country, and the other is the one that follows, which is our healthcare expenditures. And I think it's too much money being spent in too many places with a lot of inefficiency. And, you know, I mean, from the public health side, not enough emphasis on prevention. I mean, we know there are many diseases and conditions that cost us an awful lot of money. Thanks for your questions.
Dr. Samet, your unwavering dedication to public health has not only elevated crucial issues such as tobacco problems, air pollution, et cetera, but it's also inspired very tangible change. In recognition of your efforts and in gratitude for your informative and inspiring presentation today, Boulder Rotary Club is pleased to contribute in your name 100 doses of polio vaccine to Rotary International's Polio Plus campaign. As a leader in public health, you know well that for decades now, Rotary has worked tirelessly with its partners to eradicate this debilitating scourge from the face of the earth. Your own efforts in public health on the world stage amplifies this vital mission like this, underscoring the importance of collective action and compassion in shaping a healthcare future for all. Thank you very much.
Thank you.
You may notice a change in the narrator in this week's brew. That's right, we're missing Mike Brady. He's away. He's in Ukraine, in the south, in the Carpathian Mountains, at a camp with a bunch of kids who've lost their parents and who are enjoying the first respite from the war in about a year and a half. Rotation Day is coming up on September 22nd. If you've not had the chance to participate before, it's like a field day for Rotarians. Boulder Rotarians get to visit a cool local business or institution, have lunch, and learn about the place you are. This year, there's a great lineup. It's going to be so difficult to choose. There's Resource Central, the Humane Society, the Justice Center, the Center for Musical Arts, they do the Colorado Music Festival, and Fisk Planetarium. You'll see sign-up opportunities at meetings and through a link in the rib. The earlier you sign up, the more likely you are to get your first choice. And you'll hear more about this in the rib and in meetings, but this year there's a bonus tour on September 25th. The City of Boulder has offered an exclusive tour of the Water Recovery Program. Don't miss this year's fabulous Rotation Day fun. The next Boulder Rotary Book Club is coming up. It'll be at Darla's house at 5 p.m. on October 9th. We're discussing the book Unsettled, What Climate Science Tells Us and What It Doesn't and Why It Matters by Stephen Koonin. Koonin was a top government science administrator and advisor, university faculty member, and distinguished theoretical physicist. This book is about understanding climate issues, how to be a savvier consumer of science media, as well as looking at specific proposed solutions and their viability. Unsettled is described as a reality check buoyed by hope. It will be a spirited and interesting discussion on October 9th. More details in the rib, and you can see the address below. We have a new way to get people involved in service above self. Rotary Community Corps is a group of non-Rotarians who share Rotary's commitment to changing the world through service projects. They're volunteers at activities sponsored by Rotary and based on the 7 areas of focus. They're friends, people you know, Rotarians at heart, with no dues or meetings. Did you know there are more than 12,000 Rotary Corps in 105 countries? Together, we can create hope in the world. We would love to form our community corps here at Boulder Rotary Club. For more details, contact Sam Pottinger. You'll see his number and email below, but he may also be in the room. On September 8th, we have an incredible program scheduled, and it means we need to give you the details now so you can be there. The program is KUVO Jazz Radio co-founders Carlos Lando and Steve Chavez. They are award-winning radio impresarios and currently co-host the morning set. Here's what you need to know. First, on September 8th, we'll be at Fraser Meadows in their beautiful new big conference room. Parking's on the street and across the street at the church. Second, we are lucky enough to have lunch from the excellent chefs at Fraser Meadows. But because we're going to be inviting the public and Fraser Meadows residents, we must have our meal reservations in by Friday, September 1st. If you want to invite friends, family, or colleagues, let us know by September 1st. Contact Vanessa or look for the link in the rib. Next week's program is J.R. Payne. She is CU women's basketball head coach, and she's been in that position for 13 seasons. Recently, she had her contract extended to 2028 after reaching the NCAA tournament for the 2nd straight season and making a run to the Sweet 16. She works with associate head coach Tarano Towns, her husband, who she calls her yin to her yang. Join us next week for a chance to hear from a longtime CU sports champion, J.R. Payne.
Please direct your attention to the stage where we will have
a great weekend.